very, very quickly. So when we talked about our isotretinoin, it was brought up to me that what is on your slide does not say what is up here for the pregnancy test. So, and I know everybody was asleep yesterday, so now that we're all back up and running, I want you to pay attention to this because it is very important with these drugs. It is possible for you to potentially prescribe this, but most of the time, patients are going to come to you and they're already on this medication. Very rarely, I don't think that you guys would be initially starting this unless you were in a derm capacity. So they need 2 pregnancy tests that should be 30 days apart. Most of the time, people will try to take it right before they start therapy, like that day in the clinic, that second pregnancy test. Also, when we're talking about the 2 forms of contraceptives that must be used while they're taking the medication and then after they've stopped it for at least a month. If it is a male, then they still need to be using 2 forms of contraceptive with their partner, right? So they would have, that woman would have, if she has her tubes tied, if she's on birth control, what have you, they still need to be using 2 forms, and then they can have the barrier method. It shouldn't be something that is natural, meaning how people do like the calendar reading to know when they're having their cycle, or if they try to do the withdrawal or pull-out method. If they're on progestin-only pills, which are called POPs, we'll talk about those, that also is not a good method in this situation for people to use as their secondary form. So it would have to be like a combined oral contraceptive, like something that is like, we know that it has a high chance of being effective. So the more effective something is, the better, because we do not want our patients to become pregnant while they're taking this medication. Okay, so I just want to make sure that y'all understood on yours. I don't know how or why it has something that's different. So I will also go back and repost this one if you don't want to rewrite it. The next one was azelaic acid. So I was telling you about this, and depending on what you're using it for, whether it's acne versus rosacea, you can see where you're going to be required to potentially do a prior auth. So the prior auth is for when you're using it for acne. You don't really have to do a prior auth, not yet, if you are using it for the indication of rosacea. But you do see that the strengths are different. So I just want you to know that it is likely for you to have to complete a prior authorization form if you are ordering this for someone who has acne, as opposed to if you're ordering this for someone who has rosacea. Other thing was, this is hypopigmentation, not hyper, and I think I said hyper yesterday, like it would make it darker in those people. So what happens is you start to get like blotchy spots. After somebody has stopped using it for a long period of time, most of the time you will see that color return to their skin. But because they're darker, you're more likely to see it appear than someone who is a lighter complexion. Okay. I think we finished here, and we were going to start talking about our coal tar. So when you're looking at your coal tar, again, we were going over psoriasis. Remember, they have those thick plaques. Again, I will tell you what your patient has. You're telling me how do I fix it. So when we're looking at this, mild to moderate, less effective than a lot of our topical steroids when we're looking at coal tar. Also, the application for this is very, very messy, and they're going to have this thick paste on their skin, so a lot of times they're not going to want to use this. So when you look at this, just think about the fact that like you're likely to see this if somebody can't afford a prescription because it is cheaper, or if they don't want to use steroids, right? They can look at this option. But again, not something that we love to use. It also smells. Adverse effects, photosensitivity. See that this is like a thing that continues to go up or come up on our slides. And then because of the color and the thickness of it, if they have light colored sheets, then you'll see where this can also stain their sheets, their clothes, anything that they're kind of coming in contact with. You see that again with some of our animals, we see that cancer was present, so just watch out for that history. And I already told you about the fact that it does not smell fantastic. Your vitamin D3 analogs. So when we talk about vitamin D, y'all will probably go into other like mechanisms when it comes to vitamin D. I just want you to understand calcitriol is your active form. Remember, it's regulating your calcium to say, hey, am I promoting that growth and remodeling of the bone, and trying to say, hey, how can I help my patients, right? When we're looking at this and we're looking at the mechanism in psoriasis, it's not fully known, but possibly what they think is happening is that it's slowing down that skin growth. So remember, they're having that increased skin growth in those thicker plaques that keep showing up over their skin. So these are our different products that we have available for us. So you have your calcitriol, your calcipotriol that you can use, or your calcipotriene and betamethasone. So they combine it with a steroid that comes in several different formulations: foam, ointment, suspension. Remember, if you ever have a suspension, remember to tell your patient that they need to shake it to redisperse the medication throughout that vehicle that we are putting it in, okay? So ointment, several different formulations, and again, several different formulations. Just want you to be aware of what they are. Remember, looking at your mechanism, even though it's not directly known, what do we think it's doing? Okay, so we think that it's slowing down those skin growth, which helps with the scales that they have. Looking at your clinical use, again, mild. If you're using it as monotherapy, moderate to severe, we'll use it in combination. And we see that it's more effective when we have it with the steroid. So how we saw that betamethasone that was added to it, that's because we get an increase in the efficacy to try to help control those plaques that that patient is experiencing in the discomfort. Consider it for maintenance, but think about the fact that when these people are having their flares, they typically want something that's going to react quickly, and your steroids react a lot more quicker than if you were comparing this to that vitamin D3 analog. So just kind of think about this as one of those things that you could put on later for maintenance to try to like help the appearance and kind of keep a flare at bay. But initially, what you would be having somebody on, if they're trying to have quicker relief or you're wanting quicker relief, you can use your steroids for that. Looking at all of this other stuff, just understand that we're not going to use it with any acids. So if we have a drug and you see acid at the end of it, you're not going to want to use it there, because what will happen is it will inactivate your medication, your vitamin D3 analog. So what we try to do is we can try to say, hey, I can give them something else, or I can have them do one, like the steroid or something, or if they have an acid in the morning, and then I can give them this medication at night. So just make sure that they're not giving it together. If it is something that you have them putting on several times throughout the day, you can't avoid that, then either change that other acidic medication, or you can just change the vitamin 3 analog if that is an option and you don't want to put your patient on that, okay? Looking at your calcitriol, we talked about this already, but understanding that you have different efficacies based off of the formulation that you give, because remember we had 3 different ways, or 3 different components. So you have your calcitriol, your calcipotriol, or your calcipotriene, and then you have your calcipotriene that was with your betamethasone. So you have 3 different forms of the vitamin 3 analog that you can give. What this is saying is that your calcipotriene and your calcipotriol are equal in efficacy, but the side effect profile is better when we're talking about our calcitriol, okay? So less skin irritation, so more tolerable, your patient is more likely to take it. So if you had to pick between the 2, then this is a better option because it has less side effects. Looking at our adverse side effects, same things that we talked about. You see these, like, again, recurrent things. So itching, skin discomfort. When we're looking at your patients who have any type of disturbances with their calcium levels, we want to watch out for that, because again, we're giving them this vitamin D3 analog. And then when you have your calcipotriene with your betamethasone, because of that steroid in it, you can see that we have to watch out for your HPA acid suppression. So making sure that we're not putting it in places where our skin is very thin, or where we can have a lot of increased absorption. That's why you see that we're avoiding these areas when we're talking about our talcumets. Your tazotine or your Tazarac, again, several formulations depending on how your patient is presenting. Mechanism of action, this is also our retinoids, one of the things that we had talked about yesterday, vitamin A derivative. Understand that, again, when you're looking at your mechanism, helping with that differentiation and proliferation of the skin. So because, again, those plaques and the underlying issue that the patient is having, we're trying to disrupt that so that we can improve the appearance that they have. And then you also see, I bolded the inhibiting your neutrophil and your monocytes from all coming to that area, and again, making it worse for your patient. Mild psoriasis, but if I add it with my steroid again, I'm going to get an improved efficacy. So the same thing like we just saw on the previous slide. You also see that we can use this in acne, which is when we already talked about it. Adverse effect, your irritation, and then again, those genital areas, skin folds, face, especially if it is combined with the steroid, we want to watch that because then we have increased absorption and we can see that HPA axis suppression occur. Photosensitivity, and then your teratogenicity. So making sure, again, this was on that acne slide where we had the ones that were absolutely, we couldn't use them in our category X. So this is again coming up. So your Terazac is the one that you're worried about. Acitretin or Soriatin, I kind of in my head try to pair this with when I'm thinking about my isotretinoin or my Accutane, because this also has a program that is associated with that we'll talk about. But again, it's a retinoid helping again with that decreasing of the inflammatory response that we have. Monotherapy or in conjunction with that UVB therapy if the patient needs it. So remember, we can kind of go through that and see like, hey, do they need the UVB or do they not need the UVB? This is also, again, just giving us that added benefit to have versatility when we're talking about our treatment. So if one thing isn't working, this is very friendly with working with a lot of our other drugs, and it's easy for you to kind of stack other drugs on top of it. So when we're looking at this, less risk of our organ toxicity when we talk about, and we're going to get into methotrexate and your cyclosporin. These drugs are very, very toxic. They interact with a lot of things, and what we're seeing with this is that we don't have as many of those interactions. So if I can help my patient stay on a medication like this prior to having to use one of those medications, I'm better off, and they're better off. So we'll talk about those in a little bit. Looking at my adverse effects, again, this is why I told you I kind of try to group it when I'm talking about my Accutane because I see similar effects. So alopecia, the chapped lips, they'll also still have that photosensitivity. I told you guys about the triglycerides and the hepatotoxicity when we were looking at our Accutane. It wasn't on the slide, but I verbally said that to you. Same thing when you're looking at it here. You're going to monitor them for those things, okay? So kind of just put these two together. When we're looking at our pregnancy, again, just making sure we're avoiding it in pregnancy. So we talked about our Accutane, and that one had a REMS program, the I pledge, right, for isotretinoin. This one, theirs is called PART, or it's called Do Your Part, PART, and so it's supposed to be pregnancy prevention actively required during and after treatment is what their thing stands for. So it's the same kind of idea of what we were monitoring with our Accutane. It's the same thing that we're doing here, but theirs is just called a different name. So just make sure you understand that you're going to have a program where you, the patient, we all have to be involved in that, okay? Your TIMS, when we're looking at this, we saw this with our dermatitis. So again, the same exact mechanism, same exact drugs that we already talked about. But now we're talking about it in the terms of psoriasis. So more so for your patients who are going to be mild. You see that I can also use this again. This was my steroid sparing drug to kind of help me prevent or not progress to having to use steroids. Same side effects, all of this, your cautions, all of that same exact thing, black box warning, the cancer, right? So make sure we're watching out for cancer, a person who has a history of cancer. And then again, short-term use, or if you have somebody on it for a longer period of time, you take them off, give them a break, and then you can put them back on it again. Usually we'll say 2 to 4 weeks is when they have their break from continuously using a TIMS. Your cyclosporin, so this was the medication that we were talking about previously. You see that we have different brands. So you see here, cyclosporin is the generic, but you have Sandimmune and Neoril as the brands of this same thing. If a patient is saying that they are taking one, That does not mean automatically that they can take the other. So that's what it means by they are not bioequivalent. The patient may not respond well to one, and they could respond to the other. So don't just say like, oh, well, we are currently out of stock of that one, and I know that you typically take the Santamune, so I'm just going to put you on the Neoril. It doesn't work like that. We have to figure out how, that's the pharmacy's job, how can we go ahead and get the brand that they were on if they are on a brand, okay? Looking at the different ways that they're formulated, you see that you have one that's an immediate release capsule, and then you have another one that is formed in a different way with an emulsion. So that's why you sometimes also see that variability in between those two and why they're not just interchangeable. Looking at your clinical use, this is like one of our last line things. So when I say last line, I mean that patient, bless you, has to be very severe, or they've been refractory to every other thing that we tried to give them. We're not getting a response. That's when you go to these because of the amount of interactions, because of the toll that it takes on that patient's body. Okay, so severe, refractory, or extensive. Okay, not the first thing that you jump to unless your person, again, is on that very severe end. And most of the time, we will still try something else before we put them on these, especially if a patient is on any other medication. So whenever you're looking at this, again, you see that when we're talking about where there's a lot of that involvement, because remember we were talking about 5%, 5% was our marker, and when we were looking at our mild versus our moderate to severe patients. Alternative to our biologics, or if somebody doesn't have insurance and they're trying to save money, these are a little bit cheaper because they are capsules, and so it is cheaper. But again, if we run out of stock of one, we have a lot of issues in the pharmacy, and we have a lot of issues as providers to try to get that patient covered if we do have them on one of these. So again, try to not use these if you can, but they are great medications. You can use them with your topicals to try to see if you can improve the response that your patient is having to just one of them alone. And then because of those adverse effects and all the interactions that I keep telling you about, that's why we don't love to use these. That's why we reserve this for last line. So cancers can occur, triglycerides, hypertension, several drug interactions, nephrotoxicity. So there's a lot of monitoring. If you ever see one of these drugs on board, if you ever see cyclosporin, run an interaction checker before you prescribe anything, because it likely interacts and it will tell you what you need to do with that other drug or their cyclosporin dose if that one is effective. Oh, and you see here it says monitor use with pregnancy. So it's a category C, not something that we would love to give for a pregnant patient, but if they needed something and we needed to treat them, this is an option that we have available. Apremilast or Otezla, lots of commercials have been coming out for this medication. So PDE4 inhibitor, decreasing again that inflammatory response that we have. If you prescribe this, you are likely to have to fill out a PA, a prior auth, because they want to know why did we have to get to this medication. So again, on and off the formulary depends on what's happening right now. This is one with the prior authorization. Moderate to severe, and then these are your patients who are also probably going to be getting that UVB therapy, and they're probably not going to be on topicals anymore by the time they get to your Apremilast. Adverse effects, your efficacy. So you see when we're looking at this and comparing it to your cyclosporin, and this is what becomes very difficult for you as a provider, is you're going to have drugs that you can use for several different things. But then you have to start making the decision on, am I worried about efficacy or am I worried about the patient's comfortability, and which one do I value more? And it kind of also depends on your patient. Because if it has a horrible side effect profile and they don't take it, then you're not going to have a drug that's effective anyway, because it's not going to be in their body, it's going to be in the bottle. Okay? So try to make sure that you're balancing these two things with any disease state that you're dealing with. So less effective than my cyclosporin, but more tolerated, right? Less interactions, but it still has a lot of interactions, but less than when we're talking about our cyclosporin. I think about cyclosporin like a cyclone, like any drug that somebody takes, like it probably interacts with that drug, okay? Adverse effects, when we look at this, a lot of GI issues, and because of those GI issues, some people may lose some weight, but that is not, the intended cause of it. Looking at headache, watch out for anybody who already has suicidal ideations or depression, because this can also cause some of those disturbances as well. Contraindicated in our patients who are pregnant. And then our interactions, If somebody has a inducer, that's all I want you to remember. You don't need to remember your 384. Then you can see that that is going to interact with that. So if you see that somebody has a SIP inducer on board, then we are worried about the effectiveness of this. Methotrexate. So when we look at methotrexate, again, a very good drug. The dosing can sometimes cause issues with patients, so we have a lot of medication errors that can happen around it. But essentially, folic acid antagonist that's inhibiting that purine synthesis, okay, so that we're trying to kind of, again, help decrease the inflammatory response that your patient is having. So anti-inflammatory, immunosuppressive. When somebody is on this, the longer that they're on it, the more susceptible they are to other diseases because of that immunosuppressive property. Okay, so again, that's why you see this at the end. It's more so like reserved for our severe refractory, very extensive cases. They're not responding to anything, and we're trying to layer on therapy. That's where you'll see this. Looking at this, you're less effective than our biologics. And then the way that I try to also help you guys remember that it's category X is it has methotrexate, has an X in it. So we do not use this in our pregnant women either. Adverse effects, lots of them. We have what's called that mucosal ulceration. So typically if we're going to give methotrexate, we will give it with folic acid to try to help reduce some of that stomatitis that they're going to experience. So methotrexate, folic acid, and it'll take both of those to try to decrease the effect. So that's what your folic acid is on board for, is to decrease the side effect of the stomatitis. You have GI issues essentially that are occurring. Remember we said that it was immunosuppressive, so that's why you see that myelosuppression that is listed there. So again, just make sure that you're monitoring them. This drug, you have to do a lot of work whenever you have somebody on it. Toxicities, hepatotoxicity, pulmonary toxicity. So again, more monitoring for the provider who puts them on this. So that is again why we have it as one of those last line things. Already talked to you about the category X, but we typically don't see things that are talking to us about our males. So you see this one has specificity for the males and the females. So 1 month for 1 month after that woman has her menstrual cycle, and then 3 months at least for the man, so that they can have all new sperm that wouldn't be having any of this medication in it, like they form that. Your reversal agent, again, leucovorin, and essentially what that does is it then will replace that cofactor that methotrexate normally would block. Okay, so if I gave someone, I told you there's a lot of drug adverse drug issues that we have with this. Okay, so like people will not read it and they'll be taking it every single day. We have lots of things that happen, and some of your patients will come in and need a reversal. So just remember your reversal agent, because that is important. So you have your leucovorin. Looking at our biologics. So when we talk about biologics, remember that most of the time they're going to end in MAB. We have one that's kind of different, which is their etanercept. But essentially what that's doing is it's trying to stop the inflammation. So those cytokines that we will see kind of coming to that area is trying to block those so that our T cells don't get activated. Right? If I stop that, then I can decrease the inflammation that my patient has. You see that we have several different ones that are available, but these are the ones that we like for psoriasis. So your adalimumab, your infliximab, your etanercept, and your ustekinumab. All different options for your patient. A lot of them are sub-Q. We have IV options, which would require them to come in and get an infusion of it. So just, again, it just depends on what your patient would prefer. Also, cost is a big thing that comes into play here as well. Moderate to severe psoriasis, and understanding that you can combine this and add them on to other treatments if they are not responding very well to them. But again, what does my patient want to do? How many meds do they want to be on? Is this something that they are willing to do? They can also use these monotherapy, but most of the time we have them on because it increases the effectiveness. When you look at your infliximab, I just want you to remember that this one is IV and it is the most effective one that you have. So infliximab has an I, so then you can remember IV with your infliximab. Less toxic when we're comparing it to our methotrexate and our other medications that we talked about before, because remember we had that hepatotoxicity, and so we were having to monitor a lot, lots of different types of toxicity. So when we're looking at this, less toxic to my liver, my kidneys, my bones. So overall, better side effect profile is what we're saying that we have here. Bless you. Okay, warts. Several different types of warts that people can have. We talk a lot about HPV. There's lots of commercials now. We have vaccines that we're trying to use to help with HPV. But understand that it's not just genital types or like STD types of HPV. There are several different types of HPV, so it doesn't mean that that is the only way that somebody got it is through sexual contact. Looking at your all of this other information that's on here, I just want you to know what we're talking about, warts, or I could say an HPV infection. And then these are some of the prevention and treatment options that we have available. So like I was just telling you, we have different immunizations now that you'll see a lot of commercials for. They're composed sometimes, depending on the manufacturer, of different strains of HPV, and it will tell you which ones they cover. Most of the time, it's the more common ones that are affecting everyone. So you have Cervarix and Gardasil that you have that are available, and again, trying to just prevent the infection from happening. You see on commercials that the age in which they're starting to administer this continues to drop, because we do have people becoming sexually active earlier. So you'll see like some commercials where they're like, bring in your 9-year-old, or they have kids that it looks like they're dropping off to elementary school, and they're telling you to bring them in for their HPV vaccine. So just pay attention to the fact that as the age continues to change on this, that you're staying aware, so that you can recommend the appropriate vaccination. CDC website will also have like the vaccination schedule for you. What this is doing, when we talk about a wart that is on the skin, because some of them can be cervical, like so on the inside, and we have some warts that are going to be on people's skin. So what we will try to do with some of our medications is destroy that wart, okay? So this is different agents that you have. So your keratolytic agents, which are the most common types that we use, or you have cryotherapy laser, and depending on how bad it is, or if it's very reoccurrent, you can also try to do surgery to remove it. So when we're looking at our keratolytic agents that we have available, salicylic acid, pedalifos, pediofilum, imiquimod, and your cyanocanin. When we're looking at this, there are several different options that you have available. It depends on your patient. Some of them, they can get them over the counter. Some of them, they're going to have a prescription for them from you. So it just depends on which route they want to take. Some people will come to you after they have already tried the salicylic acid and it didn't work effectively. And so now they're wanting something that's going to be a prescription. If somebody doesn't have insurance, some of these do cost more than others, so just keep that in mind, like if we're talking about prescription-wise, and we'll go through some of these. So when you're looking at your imiquimod, we have several different options that are available. It's a cream, and it comes in like this long strip of like individual packets for them. So they rip off the one, and then they'll use that one that day, and then they just rip them off, okay? So it's not like a tube of cream, it's just several different little packets. What this is doing is it is inducing that cytokine induction, and therefore you'll start to see where that wart will get dry, and it will start to eventually fall off, which is what we're wanting it to do. So you see that we have external use only on any part. So if somebody has it on their skin, they have it in their genital area. You'll have some people who have vaginal or genital warts, and you also can have some people who have them and they're recurrent around their penis area. As long as they are not taking the cream and inserting it inside of their rectum or inside of their vagina, it is fine for them to use it. This is only for external warts. Because again, you can have warts internally also. So make sure that you're letting them know that it is for external warts only. When we talk about warts that people can have, like our plantar warts, which are very common, sometimes, like I told you, people will try to start with that salicylic acid, which is over the counter. They can try to do it themselves. If it doesn't work, then they may come in and you can prescribe your Nickelboon in addition to that salicylic acid, and sometimes they will achieve that termination of the wart. So just understand that you can try to use these together, and it is just as effective as you trying to freeze off that wart for them. Looking at this, you see that there are several different other uses, right, that you can use it for: skin cancer, different types of growths that people may have on their skin or their face where you're trying to get them to kind of fall off. We can use those there. We don't know how it affects our pregnant women, so just make sure that we're avoiding it. And then looking at your adverse effects, a lot of itching. Some people will have redness. Those are probably the two common things that people will say that they experience. So again, just make sure that you're letting them know. The longer that they use it, sometimes the more comfortable they will get with the medication, and they don't have these side effects happening to them. Looking at your other options that you have, and more likely seeing when we're talking about our genital and our perianal warts. So here you have your podophyllax or your podophyllum resin that we can use. Again, they both have the podophyllax in it, so just if you remember these names together, then you can kind of remember what's going on. Mechanism, we don't know, but what it does do is kill the wart, so that's why we know that it is effective for us to use it. Again, make sure that they're only using it externally, not internal. What they're doing, this is like a tapered dose. Don't need you to remember that, but what I want you to know is that they're going to have to repeat this several times, most of the time, for them to achieve the result that they want. Okay, so they're going to use it for twice a day for 3 days, and then they stop for 4 days, and then they will have to do a reapplication. And most of the time, you can get up to 4 before you have to like take a break from using it and say, hey, this is a treatment failure, and try to put them on something else. Unless that wart moves to a different site. If it's the same wart at the same exact site, and you've gotten up to that 4 times, then we need to start looking at other options, so laser, cryotherapy, surgery, to remove whatever that wart is. And sometimes that is what happens. We like to do surgery, and so especially if you're somewhere that's a teaching hospital, so a lot of times they'll have to go in and surgically try to remove those warts for the patients. Adverse effects, which is a big thing with this, and it is very difficult depending on where your patient's wart is. Make sure that they can apply it only to the wart. If they get it on any healthy skin, that healthy skin will also start to die, like the wart, because that's what it's doing, it's killing it, right? So we want to make sure that they can see where they're having to put it, because if they are putting it on their actual skin will also start to slop off in that area. So again, make sure that you're not using this in any of our pregnant patients. Skin necrosis is the big thing that happens with that. Okay, when we're looking at our Verigen, we don't use this medication a lot, but it's your Cinacapcin. I haven't seen this. It's very expensive. Sometimes it's on the formulary, sometimes it's not. Your mechanism is here about like upregulating apoptosis. So if I have apoptosis, essentially that's going to make it die, like that. Those cells are going to die, so that wart will eventually fall off. And so when I'm looking at this, apply daily for 16 weeks, so that's a longer time that you're trying to make somebody be adherent to this medication for that wart to resolve. And then avoiding it during pregnancy, $200 for a 15-gram tube. So granted, they're only putting it on a wart, and hopefully they don't have a lot of them, but again, it takes 16 weeks for it to, up to 16 weeks for it to resolve. So it's not a very smart option, I guess, to use. And then when you're looking at this, the effect that they're saying, the medication with the clearance of it, the medication was 55% and placebo was 35%. So it's not even like having great efficacy. So not a fantastic option, but it is one of our drugs that you will see. Okay. y'all want to take a break now and keep going, or wait until our 15 minutes and then take it? I'll keep going. Okay. When y'all start doing that, I just make a decision. So, does everybody have a sheet, the Dicky table, a copy of the Dicky table with them? Remember, if you don't write on them, pass them back down. There is also a copy on Canvas, and during the exam, I will provide you with this so that you know what to do with your patients. So I'm not expecting for you to remember all of the different contraceptives that we have. Okay, our ELOs listed here, same things. You're also going to be picking contraceptives for your patient on the exam. You're going to be having to know, like, hey, if my person comes and they have this type of response to the contraceptive, what do I do? What if my patient continues to spot for a very long time while they're on their medication? What do I do? We're going to talk about those, and so that's like a big part of the exam. The mechanism for this is going to be very simple once you learn what your estrogens, your progestins do. Because that's what our birth controls are. They're combined with either estrogen and progestin, or we just use estrogen in some, if we use estrogen in just some, or we'll just use progestin in some of them, okay? So that's kind of, when we go through this, the heavier lift on this slide deck and for your exam purposes is picking the right contraceptive and knowing what disease states are going to exclude somebody from using certain types of contraceptives. All right, so very brief background. When we talk about our estrogen and progesterone, just understand that that's like causing negative feedback for us, and what we're trying to say in our pregnant patient is, hey, our GnRH, our FSH, our LH, remember all these things that we talked about? We all get to women's health, y'all are gonna have to learn that table. I don't want you to know that, I just want you to know that because of the fluctuation when we're talking about in pregnancy and trying to prevent pregnancy, that's why we targeted those specific hormones. That is why we targeted estrogen, and that is why we targeted progestin. And we can use these to help prevent pregnancy. We can use these to help control how someone has their menses or their period. We can use these in different types of situations, and we'll look at the several different clinical uses that we have. But just understand that, like, background-wise, I just want you to know that we're using these medications to kind of alter the response that we're seeing in our patient, whether it's to control their cycle or to prevent pregnancy. FYI, this just again telling you about the sex hormones that are involved here, and you'll learn more about that later. Terminology that I want you to pay attention to. So when we're talking about ovulation, this is that egg has gotten released from the woman, and it can be fertilized if there's sperm that is present that meets that egg, and then you have a pregnancy. Okay, so ovulation is just saying, hey, I've released this egg from the ovary. When you talk about your menstruation, that is someone actually like bleeding, right? So they're going to be shedding their endometrial lining if there is no pregnancy. Most women who are pregnant will not have a menstrual cycle. Some women somehow still may have spotting that they think is a menstrual cycle, and some people it will happen around the same time that their body was supposed to have a cycle. So it varies. And some people, if they're on birth control and they end up getting pregnant, they may not have a cycle while they're on their birth control, so they don't even know that they're pregnant because they didn't have a cycle anyway. So there are several different ways that we can sometimes not have a menses, or we have a menses, but it could be very erratic. Maybe it doesn't happen around the same time every month, and so that's why I want to be on a contraceptive. Okay, so understand what a menses or menstruation is. That's when someone is actually bleeding. And then the endometrium is just the lining of the uterus. If there's no implantation, your body will try to get rid of that lining because it doesn't need it, the baby's not implanted there. This is what I was telling you guys about that y'all will learn in women's health, so you can FYI this. Only thing that I want you to make sure that you understand is what it means whenever you hear the word menses. It means that someone is bleeding, okay? That's all I need you to know. They're on their cycle, they're having a period. That's our non-medical term. Same thing here. just going over that cycle with you again. You will learn this later where you have to know all of the different levels. I just want you to see that this is sometimes what our drugs are mimicking. Our drugs can hormonally mimic what we are expecting to see in an actual menstrual cycle, and we are trying to control that with our drugs instead of the body doing it. The way that we do that is we have contraceptives. So there are several different types of contraceptives that can be available. There are several different ways for you to prevent a pregnancy if someone does not want a pregnancy. So we have condoms. There's male and female condoms that are available. We have cervical caps, sponges. There's all different types of things. Some of these methods may require you all to insert them, and some of them may not. We have spermicides. Make sure that you're counseling your patient properly because certain spermicides can dry out a latex condom and then the condom breaks and they end up pregnant anyway, which is what they were trying to prevent. You have sponges that can be inserted and they essentially will try to block and absorb the semen from being able to get to the egg. Looking at your IUDs or your intrauterine methods, you have copper and you have hormonal options. Sterilization, so that would be like us trying to put an implant that will actually block the release of either an egg, so that way you are preventing pregnancy, or you can have a tubal ligation, which is how we say someone had their tubes tied, and then you see the vasectomies that are available. And then our hormonal methods that we have, these are going to be several different routes in which you can give them. The most common that we sometimes are using if we're doing hormonal methods that are non-invasive are typically going to be your combined oral contraceptives. You have patches. They used to be very popular, not as popular anymore. We'll talk about that and why. We have rings that are available. So the patient would insert the ring vaginally, and that helps them with their contraception. And then we have injectables, we have rods, there's all these different types. And sometimes depending on what we are trying to achieve, you have your emergency contraceptive pills, which is also kind of combining these different hormones that we're going to talk about, mainly estrogen and progestin. We will have different hormones that we're going to have at several different levels, okay? So understand lots of routes that we can help our person not become pregnant with. All this is telling you, don't need you to remember the percentage, is that different ways in which we can prevent a pregnancy have different effectiveness. So if I have an implant, IUD, vasectomy, tubal method, you see that it's pretty effective. Why do you think that's the most effective option that we have?
Less user.
It's easier. I don't have to remember anything, right? The provider put it there, and it's like the provider said, hey, your tubes don't work. Hey, I'm giving you this vasectomy. Things aren't working the exact same way, right? So I don't have to think about anything. It's just done. Whereas when we start to get down here to the shot, I have to show up to the appointment, right? I have to say, like, do I feel like having the pain from that injection? When I'm talking about my pills or my vaginal rings, we'll go over some of these, and I'll pass some of these around so y'all can see them. But then the person's gonna have to take it every single day, right? Oh, today is Friday. Oh, I went out of town. Guess what I left at home? This. Now what don't I have? My birth control pills. Right? And depending on which week I'm in and which type you give me, right, now I may be missing some vital hormones that I need to not become pregnant. So then you have more issues. So effectiveness starting to go down real quick. When I'm talking about a condom, a diaphragm circle, again, oh, did you remember the condom? No? Well, too late now. Like, we're already here. Let's go. That's what some people do, right? So you have to think about that. If you can remove the patient, your effectiveness is going to be better. So you can always try to influence the patient. Like with my provider, I went back and I was like, this does not work for me. Please don't prescribe another pill because I'm not going to take it. I just wake up, I don't know what day it is, and now I have to remember to also take a pill. It's just a lot. This was me in college, okay? So you have different ways. I used to have these, and I'd have like 5 of them with different days punched out. Had no idea what was going on. Thank God I didn't get pregnant. But I also wasn't out there in the streets, okay? Don't be looking at me. I know exactly what y'all just thought. Don't do that. No. I was scared of my parents even when I was out of the house. So when you look at this, just make sure that you're understanding my effectiveness is going to start to decrease the more you involve the patient, the more barriers that you have for appointments to get to that place, their age. Some patients, if they're younger, they may be more embarrassed to have or afraid to have birth control pills. Religious reasons. Some people may not want a contraceptive at all because of their religious beliefs. So just kind of keep all these things in mind whenever you're choosing a contraceptive option for your patient. Looking at our different methods that we have, so male condoms, depending on the patient and any allergies that they may have, because we do have some that are made out of latex, make sure that you're just paying attention to that. When you're looking at your lambskin condoms, which are not made out of latex, you do lose the protection against some of your sexually transmitted diseases. So that is a big thing that a lot of people don't know and forget to tell patients. So yes, if someone has a latex allergy, you are more concerned whenever they're using the lambskin condoms, because again, you're losing that protection from an STD, which is typically why we're trying to use a condom or to prevent pregnancy. They're single use, so they should be thrown out after they're used. Your female condoms, big benefit here is that it's not latex. We see that it's plastic, so if someone does have a latex allergy, they can use a female condom instead. Essentially, it's just trying to block the sperm from getting to the uterus. We do have a decrease in the risk of STDs, but again, just the thought of and the idea of using this, a lot of people don't use female condoms. Most of the time we rely on male condoms, but they are an option for them to be inserted prior to intercourse. Diaphragms. So this is essentially a cup that will be fitted by a healthcare provider, so and they would take it and they can place it, they should be getting these replaced at least every 2 years. Some people can come in sooner. You see that there's two different options, latex versus a soft rubber, depending on if somebody is allergic to latex. Same method of, it's like a physical block, essentially. So any of these condoms, diaphragms, the caps, they're physical blocks from allowing that sperm to get into the uterus to cause a pregnancy. Remain in place. So this is essentially telling the patient that they shouldn't immediately remove it. If they immediately remove it after sex and there's still any sperm that's hanging around, they are very sneaky and they find their way to the uterus, and that person can become pregnant. So I always tell people, especially if they don't want to become pregnant, I stay on the longer side of things. I wouldn't tell them 6 hours, I'm going to tell you 8 hours. Okay? Because if you don't want a child, you just don't want a child. No longer than 24 hours is the maximum time that they should be leaving in their diaphragm. They take it, they rinse it out. They should be putting it in a pouch or something that would be away from like dust. It shouldn't be somewhere where it can get dirty. So let's make sure that they store it properly and they dry it off prior to them storing it, because then if it's wet and they put it in a container, then it can start to mold and things, and then they put it back in, you have issues. Cervical cap. Same kind of idea. So you see here, put on the cervix. It's also going to need a healthcare provider. So both of these, you need someone to fit it for them. Again, up to 2 years for the use. They're going to still need a spermicidal jelly, cream, some type of spermicide for whenever they're using it. So that way it can help with killing those sperm that are available, or that are present. Same amount of time that's staying here, but this one I can leave this in for up to 2 days instead of that 1 day that I saw with my diaphragm. Your sponges, so this is what a sponge looks like, kind of like a little donut, soft. They have up to 30 hours before they have to remove this. This can stay into place for at least, it needs to stay in place for up to, or at least 6 hours, but no more than the 30 hours. Inserting it, again, just a physical block. Your spermicide, okay, these they can buy over the counter. Again, making sure that they understand that these are either being used by themselves or they're being used with that, how we were just talking about with our cervical cap or our diaphragm. We can use these in addition to that. Most common is going to be your Naloxone 9. This one is the one that a lot of your patients can buy over the counter. Again, the formulation just depends on what the person likes to feel. It all has the same drug in them. There are variations, but most of them will have several formulations of the same drug. And then 30 minutes prior to intercourse, the closer that they can use it to intercourse, the better, because you want it to be present in having its duration of action while someone is having sex, okay? So if I put it in 24 hours ago, it's not gonna help me now, right? Because that duration of action is probably going off. So at least within that 30 minutes of them having sex, and then we already talked about how long it should remain in place. And then after we get through these methods, we're gonna take our break. Our tubal ligation, your tubal implant. This is where they are physically putting something in there, right? So non-surgical blocking of the tubes. So that way, we're not gonna be able to have that egg come down for implantation. The thing with this is if somebody does want to become pregnant later, the placement is very important. Their normal skin repair is also important. So if you have someone who scars a lot, this is not going to be a great option, because then I can have scarring. Now you scarred my fallopian tubes. Whenever I do want to become pregnant, I have scarring there that's now naturally blocking that egg from coming down also. So just make sure that you're getting a good patient history before you do any type of implant. Your ligation, so essentially this is trying to cut, tie, burn, make sure that that egg does not go through. So again, trying to just block the egg from getting down to the uterus, and then your sperm can't reach, so it's like an actual barrier, a real barrier. Your vasectomy, so when you're looking at your vasectomy, this is just trying to separate or cut off, close off the vas deferens, so that the sperm then won't be able to move out of the testicles. So the male still produces sperm, but it's just not going to be in the semen, okay? It can be reversible, and they still can potentially have children. It is just a little bit difficult to do it, and then they would be undergoing another procedure. But it is a lot cheaper for a vasectomy than it is for the tubal ligation in our females. We will come back in 10 minutes. So looking at our options that we have for contraception, we have several different options. We have several different combinations of these two hormones. So you'll have estrogen and you have your progesterone. There are several different types of estrogens. There are several different types of progestins. They continue to make new ones, and they continue to come on the market. Most of those newer ones, so like your progesterone, this is a newer one. Those are going to typically fall in your 4th generation, because we're like on newer generations, and they'll try to have different side effect profiles, which is usually why we're making more of them. And then you see here with our birth controls that we have, especially the ones that are combined oral contraceptives, which you'll see abbreviated as COC. Those have the ethinyl estradiol. That's the one that is most commonly put in most of your contraceptives that we have. We do have estradiol, and you have your mistranolol, but we don't use that often. Okay, so your more popular one is going to be your ethinyl estradiol. Your progestins, there are several different ones. Depending on which type of contraceptive you will have a mixture of any of these. So just think about like mix matching this with anything. So typically your ethinyl estradiol will be paired with one of these things. If you put someone on a POP or a progestin only pill, that means they will only have a progestin in that pill, not any estrogen at all. Because you'll have some people who can't tolerate estrogen, they have sensitivities, okay? So when we say COC, whenever you see COC moving forward, that's a combined oral contraceptive. That means it has estrogen and progestin. If you see a POP, that means it is a progestin only pill. The birth control that we have now that's available over the counter, that is a progestin only pill. It is a POP. Okay, so remember the difference between the two, and then we'll get into some more details about it. When we're looking at this, again, we have several different ones that we can use. Just make sure that you're looking at your mechanism, not so much worried about this. If you remember on this slide what estrogens are, and you remember what progestins are, you could just be asked like, hey, which of the following is a progestin, which of the following is a estrogen. So just be familiar with what they are. Don't need you to kind of know about all of this. More so, what is my mechanism doing? So essentially, our hormone replacement is trying to mimic sometimes what the body is naturally doing. So when we're looking at this, this is trying to say, hey, I want to try to stimulate the growth of your uterine lining, which we want in a normal menstrual cycle, so like the entire thing, not whenever they're actually like menstruating. Your estrogen levels will change, your progestin levels will change. Essentially, we're trying to thicken that endometrial layer so that if there is an egg that comes in implants, that you can have hopefully a viable pregnancy, okay? So that's what your body is kind of building up to, is thickening it. And then if you don't have a pregnancy, it sheds it, and that's whenever they actually have their menses and they bleed, because we don't need it to be thickened, okay? You see that our estrogen is also what causes that formation of breast tissue. So in someone who's going through puberty, you see that, metabolic processes, and then looking at the control of your LH and your FSH, also controlled by some of those estrogen properties. So just, again, make sure that you're understanding what your mechanism of estrogen is, not so much everything above it. Same thing when we're looking at our progesterone, same exact thing, uterine lining, understanding that it's dealing more so with the gonads. Again, also that release of our LH, that negative feedback system, helping with that thickening of the uterine lining is a big thing when we're talking about this. So again, pay attention to your mechanism, not so much worry too much about this, the binding sites. All right, our IUDs are our intrauterine devices. When we're talking about this, most of the time, well actually never most of the time, all of the time, you guys will need to implant this. So a healthcare provider will be the one who is going to insert the IUD. Patients can check to make sure, especially on the newer ones, that they are still in place. And make sure that if you ever insert an IUD, that you're letting your patient know that it can potentially discharge, and what that feels like, and if they're experiencing any pain, any abnormal bleeding, after a while, that they should be coming in and talking to you about that placement and trying to get it either removed or a new one put in, because some people do have complications with IUDs. Looking at your copper IUD, not something that we love to use. There are several conditions and some drugs that patients may be on to where we can't use a hormonal IUD, so we will go to a copper IUD. But you see that it can stay in place for up to 10 years, so this is an option for someone who doesn't want to become pregnant anytime soon, if ever, okay? So sometimes we can put in one and take it out, and then we will replace it with another one once that 10 years comes up. Looking at your hormonal IUD, this one usually has progestin in it, okay? So you see that it's not estrogen, but it's still a hormone. They have this progestin being released. Typically, depending on the manufacturer, we will have those in place for 3 to 8 years, depending on, again, the manufacturer, and one of them, it depends on what indication you're using it for, which we'll talk about it towards the end of the lecture. Looking at our vaginal rings, so these are inserted vaginally by the patient. You don't need to do it for them, you just need to prescribe it. Good thing about this is that it is plastic and it's not latex, so that's good for patients who are allergic to latex. I kind of say that it reminds me of like those little bracelets that we used to have a long time ago, those little thin plastic kind of bracelets. It's not something that's very thin. Most of the time when people put it in, they don't even remember that it's there, they don't feel it. Has estrogen and progestin in it, so now this is a combined contraceptive, even though it's not oral. You see now that you have both, not just progesterone, not just estrogen, but both of them in there. And then how this is typically the dosing for it, I guess, is what I'm trying to say. And I do need you to remember the dose, because it's an easy way for you to remember it. They are going to take that ring, they insert that ring, they leave it in for 3 weeks, they take it out for a week, and then they insert a new ring, leave it in for 3 weeks, they take it out. So 3 weeks in, 1 week out, okay? There are new rings that we have available. There's a new one where they can use the same ring for a year. They're not needing several of them to be, to be ordered. So with the new ring, they use it one time for that 3 weeks, and then they take it out and they throw it away. The new one that I'm talking about, and that we'll talk about at the end of the lecture, they'll use it for 3 weeks, they take it out, they wash it, dry it, put it in a patch, leave it out for a week, and then they take that same ring and they put it back in for up to 13 cycles, okay? So one you have where you have to order 12 of them for the year. The other one you order 1 for the year, okay? Your birth control implant, this is a rod that most of the time, whenever people have it, it's going to be somewhere under their skin, the upper arm, very small. So think about like a match that someone would have. That's the size of it. Low doses of just progestin. So again, you don't have that acid. Do y'all see that? Oh, I keep getting pop-ups on my screen. I was like, uh-oh. Somebody said, are you working with like 10 G's? Yes, I am working. So with this one, again, remember that it just has the progestin. So when you're looking at these, a big part of this is also remembering what hormones someone is being exposed to. And we'll talk about the responses that some people will have to different hormones. So that can help you with choosing the correct contraceptive method for your patient, because you have lots of options that are available. So with this, most part, it's in for 3 years. Once that 3 years comes up, they take it out. Most of the time, you shouldn't have any issues. It doesn't move. You will have some patients to where it can potentially move, and you kind of have to fish for it and find it to get it out. But for the most part, it's there. You should give your patient a little bit of local anesthesia, because you're going to cut their skin to put it in. Be kind. Don't be like, you know what, you're that patient I don't like, and not anesthetize them, okay? Not general, just like give them some injections in that site that you're going to be working at. When you're looking at this, some people will want it out, and then they'll put a new one in right when you're taking the other one out. They want another one in. Depends on them. These are very good options, because again, if I'm short term and not wanting to become pregnant, the best options that you have are going to be oral options or this vaginal ring. But if I want to extend that time to something where I'm like, not in the near future, 3, 5, 8 years, those options are where you're going to look at like IUDs and look at these implants for your patient. Okay, here are your patch. We have a patch. When we talk about the patch, so this used to be like a very, very popular thing. You put on the patch, you leave it on one every week, and then for your after your third week, you leave it off. So you have a hormone-free period, and that's usually when they would start their cycle, and then you go and you start over again. So there's 3 patches that come in the box for the month. Okay, so apply a new patch once a week for 3 weeks. On your 4th week, you're free of any of that hormone, and then you would start all over again. So that's the dosing for this. But these had such a high estrogen content to them that what we started to see was an increased risk in cancers, strokes, several different issues happening, blood clots. So we don't use them as much anymore. If you use this, please make sure that your patient is not like a heavy smoker. They don't have a history of clots or anything like that, because that is going to dramatically increase a risk that is already very high with these patches. You see several different places for them to put it: abdomen, butt, outer arm, upper body. So they have several options that they put them on. The other thing was, when people worked out a lot, sometimes people would say like that patch came off, but they didn't realize that their patch was off. So again, if I'm trying to not become pregnant and my patch is off, now I might have a problem, depending on how long that patch was off. Your injectable birth control. So with this, you have medroxyprogesterone. This is a very good option for some patients who don't want to take things every single day. But the longer that they use it, the more likely you are to see the loss in the BMD, so that bone density will start to decrease. So it varies. You can also see some weight gain in some of the patients who respond to this medication. So just an option. Give it in their arm. You can give it in the butt. Typically lasts for 3 months. They're going to be sore for a couple of days whenever they take it, because it's a long-acting injectable that we're giving them, right? So because it's slowly dispersing over that 3-month period, that's why the first couple of days after they get that injection, they're usually hurting. And then you see that bone loss during the first 2 years is typically when you see it. So the longer they're on it, the more likely you are to see that side effect occur. Our mechanism of action for our contraceptives, simply put, is to stop the pregnancy, right? So stop ovulation, figure out that implantation, right? The endometrial lining, trying to block the implantation, make it more difficult for the sperm to move in the vaginal area. So it's harder for it to kind of wiggle its way through. So sometimes you'll see cervical mucus will be thickened. So that way the sperm are going to have to work a lot harder. And sometimes by the time they overcome that thickness, they're going to be dead. So that's why you see the cervical thickness there. And then again, just some methods are going to be just blocking, okay? So Contraception is to be used for preventing a pregnancy, also can be used to kind of control ovulation as well. There's several different off-label uses that we'll also talk about. Combined oral contraceptives. What hormones are in my combined oral contraceptives?
Estrogen and progesterone.
Estrogen and progesterone. This is our most popular form. This is the one that you are going to prescribe quite a bit, okay? So when we're looking at this, you see my clinical uses, right, that I have. I can regulate someone's hormones. Contraceptive is the main thing that we use it for, but I can regulate hormones. I can regulate how someone's menstrual flow is. So you'll have some people who will say like, oh my gosh, I have such heavy like menstrual cycles. Well, I feel like I'm bleeding a lot. I'm super tired. You can try to control that with these medications. If I have a cycle where I'm like, hey doc, like I'm having my cycle like 2 times in a month, or maybe I won't have it at all 1 month, and it's just very irregular, you can give them a combined oral contraceptive, and that can kind of help regulate their cycle. So here you see all of the different things. We have certain formulations that we use for patients who have acne, and they're trying to control their acne. Again, because they are hormones that are in here, right? I can try to see if it's a hormone issue as to why they are experiencing their acne. PDD or premenstrual disorder. This is essentially where people are saying like somebody is PMSing. Essentially, that's the correct term for it. So they have all of these symptoms that are occurring to them prior to them having their cycle. We have certain medications for that. And then we already talked about the heavy bleeding. These are all of your off-label indications. Several of these we do use them for that. If somebody has extensive hair growth, talking about emergency contraception, so like our Plan Bs, things like that, you'll see these medications used quite a bit. Choosing the right contraceptive. This slide is essentially telling you there's so many different factors that go into it. Your patient, their history is vital to you choosing the correct contraceptive, okay? If somebody has underlying issues, if somebody has unexplained bleeding, different things like that, if they're a heavy smoker and they don't want to stop, that guides what you're going to pick very, very heavily. Remember, you're going to be a provider. We're not causing harm. We're trying to fix things, not break things, okay? So this is just telling you, again, get that patient history. The other thing that we don't think about is compliance. How compliant is my patient? Because are they going to remember to take this pill every day, or do I need to give them something where like, hey, you can use this ring, or you can come and have this shot, or I can give you this IUD or this implant, and then you don't have anything to worry about. And then when we're looking at the ring, is your barrier that you don't want to come to the pharmacy and wait for 5 hours? Then if that's the case, then let me give you the one that you can use the same ring for a year. Now you don't have to come to the pharmacy, right? Because now you have that taken care of for an entire year. When I did my residency at the hospital over here, I made a program to where we could do contraceptives. The pharmacist can prescribe them. So if you guys aren't available, y'all are booked, and I'm like, hey, I want to start a contraceptive, you can send them to the pharmacy and tell them, hey, the pharmacy can do it. We're not doing IUDs, implants, or anything like that, but if they need a combined oral contraceptive or a ring, a Plan B, any of that stuff, now the pharmacy here can do that. So depending on where you are, it's kind of starting to spread a little bit. You have that option as well. So just see if where you go, do they have that available. If you're practicing on the outside, depending on what state you are, some pharmacists can also prescribe contraceptives. So like if they walk into a Walgreens or a CVS, they have a collaborative agreement with a provider, and they're essentially able to write prescriptions for the patients also. So it varies on where you are. Looking at this list is very important, because this is how you are going to say, yes, you can have a combined oral contraceptive, or you can't have a combined oral contraceptive, but I can give you a pop. The biggest things that are on here, so again, we talked about active smokers. So if somebody is an active smoker or a heavy smoker, the older they are, the worse that it is. So over 35, which seems young, but anybody who is 35 years of age or older and they are a smoker, we are going to try to stay away from estrogen in these patients, because it increases their risk of those cardiovascular events. It increases the risk of them having any of those VTEs and things like that, okay? So greater than or equal to 35 and they like to smoke, it's an issue. If they're younger and they're smokers, we have a little bit more wiggle room, but when they get over that 35, it's a no. History of clots, and as we continue to talk about some of these different options that we have available to treat them with our contraceptives, you'll see that these things are kind of varying depending on which option we use. Obesity, there are studies that are going on where we are trying to see if the effects of estrogen are decreased in some of our patients who are obese, so therefore the effectiveness of their birth control is not as good. We do see that in some of our emergency contraceptives where certain weights, depending on how much the patient weighs, will determine which emergency contraceptive you use. So you have some people who are like, well, I use the Plan B, I don't understand how I'm pregnant. And sometimes it could be because of their weight. If they were overweight, they had it in their chance of failure was already higher and they didn't know it, okay? So we'll talk about that a little bit. Breast cancer, other types of cancer, diseases. So just be very familiar with this. The biggest ones that we're gonna look at are gonna be probably up to this obesity. When you're seeing any of this, just think of it all as like worrying about clots in their heart, okay? A lot of this is based off of that. So, based off of that list that we just looked at, if I answer yes to one of those, right, I have one of those conditions, I may not be a good candidate for you to give me that combined oral contraceptive, okay? Whereas if I said no, good to go, you're just gonna pick one. If I don't have any of those things, there's no reason for you to avoid giving me estrogen. But if I said yes to one of those things, estrogen is my problem, and therefore I might have to use a POP, or I might have to use one of my IUDs or something that does not have estrogen in it, okay? So the idea behind that list is we're watching out. This means I'm watching out for estrogen, okay? If I have one of these present, then I may not be able to use estrogen or a combined oral contraceptive, okay? So that's what this is saying. If I said yes, you might have to give me a POP, you might have to give me another contraceptive without estrogen in it, or I can look at an IUD, and then my barrier methods that I talked about before with condoms, things like that. When we talk about the age of, yes?
Because we're giving people estrogen for a long period of time, is that going to increase their risk of cervical and breast cancer in the future?
So the dose that we're giving, and we'll talk about the different doses that we give, typically we're trying to give them lower doses, but that again also goes to that patient, right? There's several different things that could increase the risk, but the thought is that the dose is low enough to where we don't. Is that always an increased risk once you start introducing hormones to somebody? Yes, but they're smaller doses. And when you talk about that, most of the time, so there's very few options that we have where they're 50 micrograms, and most of the time we try to stay less than 35 micrograms. Once you hit those higher levels, yes, you will see that increase in that risk more likely to happen. Older women. Some of our women, even though they're not of childbearing age, they could still be having their cycle, or they could still be bleeding while they're going through their perimenopause stage. When you're looking at that, they may have very heavy cycles, and our contraceptives can help control those cycles as well. So it's not necessarily like you're using it for a contraceptive purpose. You're using it to help control how much that person is bleeding, okay? All right, breakthrough bleeding, spotting. These are some things that we have that can happen when somebody is on a contraceptive, and this is why sometimes we are trying to find the right option for that patient. Some people respond to certain contraceptives and others they don't. You can have a person who comes in, and within that first 3 months, it might be normal for them to be bleeding in that first 3 months. After that, it is not normal for them to continue to be bleeding. And when I say bleeding for the 3 months, they should be like having a heavy cycle for the entire 3 months. If they're randomly spotting, or if they have like a small amount of blood every single day, that is sometimes normal for someone when you initially prescribe them a contraceptive. So you tell them to wait 3 months before you automatically are thinking, oh, I need to change it. So you see, it could be an imbalance that is happening when I'm talking about my estrogen and my progestin. You can have a missed pill. That was me, right? So anytime you keep missing one of these pills, then you have more of a chance to have spotting, because now I had that estrogen level at a certain rate and then I just dropped it, right? So now my cycle starts. And that changes depending on where they are in their pack. And then whenever you switch, or the way that you fix this is you would say, hey, maybe I need to switch them to something else, and we'll kind of go over what that would look like. We were talking about the estrogen doses, so the higher the estrogen dose, sometimes we can see more side effects with that, but that is also how we can help decrease the amount of breakthrough bleeding that somebody is having. So we would kind of increase their dose. We don't want to get over 20. 35 is typically where you will see us try to stop. So if you started someone on a very, very low dose and you're not at 20, I would try to go to 20 before I automatically jump into that 30 or 35 micrograms. And then looking at your multiphasic, these are more difficult. We don't love to prescribe them anymore. I'm gonna pass those around to y'all too. But we have multiphasic ones, and if you look at this, this one is yellow, this is blue, and this is a peach looking color, and then you have white. So these are all active pills that have the hormone actually in it, and then the white ones are placebo pills. So they can either poke these out every day so that they can remember when their new cycle is, or their new pack needs to start. They can take these if they want to take them, they're just sugar pills. Or they can say, all right, I'm done with this pack, throw it away, and set an alarm on their phone so that they know that they need to start their next pack after a week. So if they don't take that's okay. The reason why this has 3 different colors is because the hormone level is changing. They can either change the estrogen level in these, or they can change the progestin level in these. And so every single week, that's changing. This is more confusing for a patient. That's why our adherents sometimes, whenever they're taking these, and if they forget one, they're more likely to have sometimes that bleeding occur. So it depends on this and if you use these. Most of the time, we like to use our monophasic, so you see all of these are the same color except for that placebo week, right? So this is easy for me. Cool, I can just take one of these, it doesn't matter which one I pick as long as I poke one out of this pack. It's nice if they do it in order because this says like Sunday, Monday, Tuesday, Wednesday, Thursday, so they know what day they're on, but it doesn't really matter. So this is called like a monophasic pack, and this would be a triphasic pack, right? Because there's 3 different levels, and this has just 1 level. So I'll start passing those out. So that's easy. If you need birth control, let me know. Don't take these, okay? All right. So, looking at our patient instructions, I always talk to y'all about package inserts. Whenever they get contraceptives, they'll get this little thing in their package that they will open. So when you look at this, as a patient, this can be very, very overwhelming, but it has lots of great information. So this is a package insert. If I look at this, I'm gonna be like, oh no, I'm throwing it away, right? But when you think about, like, this has all of the side effects, like literally every single one. It has what do they do if they miss the dose. It has information about their studies, all of the things, different ways that you can start them, which will vary depending on which contraceptive you choose to use. So they do have these that come in there. I try to tell people not to read this because it's like for you as a healthcare provider, even though we say it's a packet insert for the patient, but sometimes this is like overwhelming. And then if you tell me every side effect, I'm gonna pretend that I have every side effect in my brain, right? So y'all can look at these wonderful things too and see kind of what your patient is seeing in the packet insert so that you can kind of educate them. And sometimes, like as a provider, if you look at some of these things, it's easier for you to say like, hey, let me summarize this for you. Sometimes I go in there and I look at it if I want to have certain information. You can also type in the name of a drug on a website, and it typically has their packet inserts online for you to see them also. So you see that you have your patient packet insert, you have when to start. You will also learn how to tell them to start their medication because you're going to be prescribing it. And remember, we don't want them to rely on these and opening these, right? You have your active versus your inactive, so that's what I just told you, right? You have active pills, which were the colored ones, and then the inactive were the white ones, okay? That were at the bottom. They can take them, they can punch them out. Some of your contraceptives that we have, our oral contraceptives, may not have inactive pills on them, and all of them are active. When we talk about our pops, we'll look at an example of that. They should be taking 1 pill every single day at the same exact time. Now, there will be some variation. This is more strict and structured when we're talking about a progestin-only pill than when we're talking about our combined oral contraceptive. But we want to stay as close to a natural, like our regimen, right? So whatever time, every single day. If they remember at night, if they remember in the morning, if they remember at breakfast, it doesn't matter. Okay, just tell them to pick a time and stay with it. When to expect their period is very important because some people want to know, hey, when can I expect to be bleeding? I have a trip that I want to go on. Maybe I don't want my cycle to be happening while I'm on my trip because I'm trying to have fun. Now I don't have to worry about that. Okay? So you can also use these medications to help control that. And that usually happens once they get to that week that they're going to be off. That's usually when they can expect their cycle. And then again, if I miss a pill, how do I make up for it? That sometimes will vary on the level of hormone that is in that pill. Now, the most important thing, I might be preventing you from becoming pregnant, but I am not preventing you from getting an STD. So you still need to do things to make sure that you are protecting yourself from having an STD. That is what you need to let your patient know, okay? Because some people think I have a contraceptive, I have a medication, and I don't need to worry about becoming pregnant, and they forget about the other part, right? Yeah, you'll have that kid hopefully for the rest of your life, but you could also have HIV or some STD for the rest of your life too, okay? So please stress that whenever you're placing your patient on contraceptives. Okay, dosing initiation, very important, right? We have our drug, but how do I take it? When do I start this, doc? I'm so confused. I don't know what's going on. You gave me this thing. I have all these different colors. I have this packet insert. Like, I don't even know what's going on. How am I supposed to take this? So, Sunday start is our most popular. You have a quick start, and then you have a first or same day start, which means that I'm taking it on the very day that you prescribed it to me. I'm starting that day. So your Sunday start, this one is essentially you saying, hey, I started my cycle on Sunday. Let's say that today is Thursday? Today is Thursday. I started my cycle on Sunday, right? So what you're gonna say to me is, well, let's say, no, let me do it this way. I started my cycle on Monday. I came in and I saw you and today is Thursday. So what you're gonna say is, okay, you already started your cycle, so we can wait until your next cycle, or we can use one of these other options that are down here below, your quick start or your first/same day start. If it is Thursday and I come in to see you and you're saying, hey, I have these pills now, right? I have my birth control. I would start the Sunday after my cycle starts. So let's say my cycle then happens to start on Sunday. That is when I would start taking my medication because you prescribed it to me and I now have it. If I just started my cycle and I'm coming in to see you, like I started my cycle on Sunday and today is Thursday, now I have to wait until the next time if I want to choose a Sunday start. I don't have to wait if I want to start right away because I have a quick start and a first or a same day start also available to me as a patient. Your Sunday start is just a lot better because it is a preference because you see where it says avoids withdrawal bleeding on a weekend, and she can decide if that's a priority. What that means is usually your withdrawal bleeding will happen during the week when you're in that placebo week or that white part that I showed you on the contraceptive path, on your birth control path. So that allows her to have her cycle during the week instead of having it on the weekend, okay? So looking at this, Sunday start, the first Sunday after they have their cycle, that's whenever they would start their birth control, and they need a backup method for 7 days. I have to give that drug enough time to build up, to get to steady state in my body for it to provide its contraceptive effects. So a backup method for 7 days. Please let them know that it is not working immediately. Your quick start, so this is where you're taking your tablet. I came in, I saw you, and today is Thursday, and I want to start today. Also perfectly fine. So when you're looking at this, again, because I had no coverage, that drug hasn't built up in my body yet, backup method for 7 days. Your first or your same day start, right? So your first or your same day start is saying, the day that I start my cycle is the day that I'm going to take my birth control. Okay, so first tablet on the first day of menses. Remember, menses means they are bleeding. Okay, so as soon as their cycle starts on that very first day, they will take their first tablet of that path. okay? 3 options: Sunday start, quick start, first or same day start. When you're looking at this, a lot of your packets are gonna say for your first or your same day start because they don't need a backup method. That's the only one out of these 3 that you see that does not have a backup method. The other 2, you need to wait 7 days. Not wait to have sex, but to know that they could potentially not have to use a condom. Again, not something that we recommend unless somebody is in a monogamous relationship. And remember, you don't have the STD protection if they choose not to use a condom, okay? So Sunday start, I'm starting on the Sunday after my cycle, the first Sunday after my cycle. Quick start, I'm starting on the same exact day, backup method for both of those. When I look at my first or my same day, that is me saying, hey, my period started today, I'm taking my medication today, and then I don't need a backup method because my endometrial lining is shedding. So the thought is I'm likely not pregnant. It's like the thing that you're taking, the assumption that you're making. The other thing about contraceptives, a lot of these, when you talk about birth control that you're prescribing to a patient, if someone is already pregnant, these are not abortifacients. They're not going to abort that child if they are pregnant already, okay? So you have to use your reasonable thought process, and there's like a whole bunch of different things. They don't need to necessarily have a pregnancy test per se, but you are going to ask certain questions to make sure that your patient is not pregnant. And I think y'all will learn that next semester. So this is kind of what we were talking about, and that's the packs that are going around. So you have monophasic. This is what we like. It's easier for your patient. It's a lot easier to recover if you miss a tablet because there's not different hormone levels depending on which week or where they are, okay, in that pack. Your biphasic, this has 2 different levels, bless you, 2 different amounts of hormone in it, so they split up the pack. And then your triphasic, this one is going to change every 7 days, which is like the one that you guys have. And if you look on there, I think it tells you like the amount of progestin is changing every week. And then you can also see sometimes where they try to increase gradually the level of estrogen because typically that's what's happening in the body. So it's trying to mimic what's going on. So you'll either see where it's consistent or it's mimicking. And I think in the packet that's there, you'll see that it's consistent. The estrogen level, but the progestin level is kind of going up. Your quadriphasic, again, quad is 4, so that's just showing you that there's 4 there. And then your extended cycle. What this is instead of having that last active week of those white tablets that were there, the placebo tablets, they're just active all the way for 84 days, and then they have their placebo week, and that's whenever they have their cycle. So they're having their cycle once every 3 months instead of having it every single month, okay? And you will see some providers write prescriptions to where those monophasic ones that I passed around, they will just tell them to skip the placebo week and start another one. So it's the same exact thing as getting an extended cycle one. You're just doing it with the basic ones that we have. As long as it is monophasic, you can do that. So that's what this is essentially talking to you about with the continuous. There is no difference as far as efficacy in between any of these different phases that you choose. It's more so to help with adherence and help your patient stay on track with their contraceptives. These are our different pill packs that we have available, okay? So you see 21 days, 28 days, 91 days, and those are continuous cycles that we have that are going to be available. So again, that's just telling you, hey, depending on which pack you choose, they have that placebo week that's going to be in there. And then during that placebo week is essentially whenever they should be having their cycle. If you use this 91-day pill pack, you'll see that on this one, they're having that placebo week during that 3rd month essentially of them being on it. And then your continuous or extended, you see that you're going to try to make sure that they don't. You'll hear some patients come in and they'll tell you like, I'm just taking my pack back to back to back and they're not having a cycle at all. Not recommended, okay? But you will see some patients doing that. And you will notice it because they're going to run out of their contraceptives quicker than they should, right? Because if I'm not taking my week off with my placebo, then that means that I'm taking my next pack and continuing. They're going to run out almost 3 to 4 months in that year before they should have, okay? So like, kind of pay attention to that if you see that and you can just ask them that. Again, we prefer our monophasic. When you're looking at the adverse effects of your extended or your continuous cycle, you are likely to see more breakthrough bleeding. in the patients who are taking those type of contraceptives than the regular contraceptives, because we're allowing them to have that cycle. In our continuous or our extended, we're not really letting them have that moment for their body to kind of discharge that old lining, okay? So that's why you're likely to see more spotting occur in those patients. This is for your backups or your missed tablets. Depending on, again, what type of tablet you give them, they are likely to have breakthrough bleeding happen. This is what I want you to know to make this more simple, because this can also sometimes vary depending on which contraceptive you prescribe your patient. Exam-wise, what I want you to remember is if they missed one and it's been less than 48 hours, take it right away. If they have missed two back to back and it's been greater than 48 hours, take it immediately, but now they need to have a backup method. Think about it as I was at steady state, I was in that window, but because you've had me out of my window now for 48 hours, right? There was no new med being put in. Now I fell out of that window and the chances of me becoming pregnant is high, so I need that backup method on for 7 days, okay? If I just missed one and it's been less than 48 hours, I don't need to worry about a backup method. I might have to now take 2 tablets at the same time the next day or as soon as I remember. Because I could have been on my packet and I punched it and I'm like, oh, today is Thursday, but I still see my Wednesday bill here. Now that's the first time that I realized that. Or I could have went to work, I came home and I'm like, oh crap, I forgot to take my pill today. I can take it immediately, but if it's the next day, as long as like that 48 hours hasn't passed, I'm still good, I don't need a backup method. And I can just take 2 of my pills at the same time that day, okay? And then if you have anything else like outside of that, they probably need an emergency contraceptive if they had unprotected sex. And sometimes we'll tell them to throw out that pack and start a new pack and then just allow their cycle to go ahead and occur. Because they'll be spotting so much and trying to catch up, and it's going to throw everything off. So if you start to see this happening very frequently, then you need to look at a different option for them. Whether it's the ring, whether it's a shot, implant, IUD, what have you, depending on how soon they want to become pregnant, okay? So if they're in their 2nd or their 3rd week of that pack and they're missing, tell them to just skip that placebo week. We'll tell them to start a new pack, or we'll tell them to use a backup method, go ahead and have their cycle, and then we'll get them back on track, okay? So simply, 1, less than 48 hours, take it as soon as they can. 2, and it's been more than 48 hours, so 2, more than 2 days, take it as soon as they can, and they need to have a backup method, okay? 2 days, backup method for 7 days. 1, less than 2 days, they just need to take it as soon as they can. That's all I need you to remember from this, instead of trying to do all of that, okay? We have a lot of different benefits that we get whenever we're using our combined oral contraceptive, right? So less cancers, because again, remember we're using it at those lower doses. We're kind of, and this depends on what stage they are in their life with the levels of estrogen. So y'all will talk about that more probably next semester. But that depends on your patient. Your cysts going down, breast diseases, fibrosis, ectopic pregnancies, all of these things, like if I have irregular, heavy cycles, some of that will go down. Sometimes we'll have contraceptives to where it will decrease the bleeding or it will stop bleeding altogether for some of our patients. They'll say like, hey, I haven't had my cycle in a long time. And that's okay too. It depends on which type of contraceptive you give them. Most of the time you'll see that with some of our IUDs. Another question that we have sometimes with breast cancer. So this depends on the research that is going on at the time and what's happening. Can be conflicting. So when you are out of school and you are actually prescribing, I would look at it at that time to see what research they have at that time. The CDC is a very good website to use to look at that. So just when you're looking at this, just put, can we use it if somebody has a history of breast cancer? We're gonna, y'all are definitely gonna use the neck chart next semester, but that's the medical eligibility criteria that they have on the CDC website, and you can use that to also prescribe contraceptives. I just want y'all to use the Dicky table because it gives me an aid to give to you, and this is all the stuff that we have on the formulary in the DOD. So that's why I give you that one versus the MEC chart that's on the CDC website, because it has every single contraceptive, and you wouldn't be able to use it in the test. Just make sure with this that you're understanding, can you potentially use it? Yes. Potentially, depending on what's going on. Your estrogen and your VTEs. So when we're talking about this, the higher the dose, the more likely you are to see a VTE occur. So that's why we try to stay, if we can, below 20, 30 is also acceptable. Once we start getting into those higher ranges, like over 50, we typically will not do that. There are very, very rare situations to where you'll see that, and it could be because there's like a drug interaction with the contraceptive, and so you're trying to get that dose of estrogen higher because we know that the drug that they have on board decreases the efficacy of the estrogen. So you're kind of trying to combat it, but the issue is if you overshoot that, now you're causing more harm to your patient by giving them a high level of estrogen. So just make sure that you understand that DVT risk is going to increase as you increase the level of estrogen that somebody is giving, and we want to stay ideally below 20, but less than 30 is also, less than 35 is also acceptable, and you'll see that in some of your contraceptives that we have on the Dicky table. Cardiovascular complications. So this is, again, one of those things that we're worried about when we're using estrogens. Higher the dose, more likely we are to see this. Also, you see that smoking, right? Other things that we could be doing that could increase my risk of having any type of cardiovascular complication. I'm also worried about that. Over 35, and I'm a smoker. If I'm over 35 and a smoker, even worse. And then you see all of these absolute contraindications in my smokers who are over 35. But a relative, if I'm younger than 35 and I'm a heavy smoker. Okay, so if I'm smoking cigarettes for breakfast, 15 cigarettes a day, that's a lot of time spent smoking a cigarette. How long does it take to smoke a cigarette? I've never smoked a cigarette, so I'm just, now my mind is going, I never thought about that. But that's a lot of cigarettes, right? So if I'm younger, it's a relative contraindication, meaning I could potentially still use a combined oral contraceptive that has estrogen. But if I'm over 35, right, and I told you that I smoke, then I'm now worried about, hey, this isn't say absolute contraindication. So that's our absolute versus our relative. Lowest dose of estrogen possible in these patients and in any patient who has any type of increased cardiovascular risk. And then you also have the option to potentially use a progestin-only pill, but again, we don't love using our progestin-only pills. A black box warning for anybody who smokes and has any type of cardiovascular events. This is on every single combined oral contraceptive. They have a black box warning for that. So please make sure that you're remembering that. This is our Dicky table that we have. So I want you to take a look at your Dicky table. You have front and you have back, and you have all the different ways that you could potentially be giving someone a medication. So when we're looking at this, you see that we have our 50 microgram, 35, 30, 25, 20, and this is telling you the estrogen component of it. We don't love, and very rarely will you see us reaching for that 50 microgram because I have those increased risks that we just talked about, okay? So that's not something that we would prefer. But you're going to see endometrial activity, estrogenic activity, progestational activity, and your androgenic activity. I'm going to correlate this to the slide. So what you're seeing up here at the top, you would go down and you're going to read these numbers to say how much activity does that have, does that contraceptive have. The higher the number in that box, the more activity that it has. If it says 0 or NA or super small, then that means that it has less, right? So you'll see some of them where they don't have any estrogen activity, estrogenic activity. You'll see some where they might not have any androgenic activity. So that's what you're looking at when you're looking at these, and that's going to be based off of your patient and the complaints that they have whenever they come in. So, looking at my estrogen sensitivity. So these are going to be your patients who are sensitive to estrogen, so you want to use the least amount of estrogen that you can. Sorry, hold on. Did you want Colonel Color to start early? So she coming at 2:30? Okay. We'll do this later. I don't want you to try to rush through that because it's going to be important for you to know. So, we'll start here. Please don't forget these tomorrow. Keep them and don't forget them for tomorrow because we're gonna need them.
Thanks.